I started working almost 30 years ago, and at this time, this was probably the dark time of hemophilia. Because at this time, although there was a progress in the management of hemophilia or in the care of hemophilia due to the development of factor concentrates in the 70s, yet at this time, the world did not realize the transfusion-transmitted infections that can be transferred to patients from the plasma concentrates, particularly that it was produced from a large number of donations. And consequently, in the early 80s and mid 80s, the hemophilics faced a disaster by especially in the developed world, where the concentrates were prevalent. And at this time, more than 50% of patients had HIV and hepatitis C. And many of them, unfortunately, died due to HIV, even including the Mr. Frank Schnabel, who was the founder of the World Federation of Hemophilia. He was a Canadian hemophilic, and he did a remarkable effort to develop the hemophilia care on the international level when he founded with 9 other countries the World Federation of Hemophilia. In the meantime, the research we developed, we could identify the defects in the genes that cause the hemophilia. And consequently, we also could be able in the early 90s to develop what was called the recombinant factor concentrates, the concentrates that are produced by recombinant technology and not derived from the blood, which gave higher safety. And so consequently, this led to a very important thing, is that for the first time, we were able to give the factor concentrates on regular basis, not only to treat the bleeding, but in order to prevent the bleeding. And if you prevent the bleeding, you prevent the long-term complications. So this is, I mean, like a very brief history of a very old disease. You know, the hemophilia was identified even BC. But, you know, it took hundreds of years to develop the care, which means that everything takes time and needs patience. In the meantime, the interest was very focused in a very small group of people. So in 1971, one of the fathers created, in cooperation with some of the medical professionals, the Egyptian Society of Hemophilia. As they were very much concerned about the patients, they did not want anyone to share them the knowledge about the disease and how can they help, which delayed the improvement for a very long time. And at this time, there was a great resistance. The people who are in charge, they did not want to open channel with abroad, or did not want to involve more stakeholders inside the country, believing that they are doing the best and there is no need to. So this was one of the challenges, the ownership. We could together, I mean, build plans to bypass the resistance and to try to open channels and to try to get into action through the international collaboration. And in 2003 or 2002 in Sevilla, we had a meeting of the World Federation of Hemophilia Congress. And there they were developing a brand new program called GAP, Global Alliance for Progress. And the main objective is to build a national hemophilia care system that can be implemented to the national health system of the countries. And there was an evaluation of the infrastructure of the country, the capacity of the country, and based on this, they started to choose the countries that can fit into this program. As we say, our community is global, but each country has specific needs. So, I mean, in Europe and in the US and in developed countries, the disease is the same, but the conditions for diagnosis and management was by far much better than in other countries, because by coincidence is that the prevalence of the disease is global, 1 in 10,000. So it does not differ due to ethnicity or geographical location. So it's the same disease, but there are different circumstances. And that's what I could see from the experience, is that you need to look into the special conditions in each country in order to put a program that can respond to the culture, respond to the economic and geographic conditions in order to move forward. So if we look to the access to care, it must still have limited access. We say always that it is 2080 or 2575 equation. 25% of the patients with hemophilia have the right access to almost 80% of the care around the world. And then the remaining 20% of the care are only available to about 80% or 75% of the global population. When we ask governments that we have to take care of these patients, they need evidence, they need data, they need justification of cost, because usually the care of such disease is very expensive. Medicines are very expensive, diagnostics are very expensive. So the government needs to have data. Data is the very important thing that you need to generate in each community, because according to the robustness of the data and the inclusiveness of the data, it will reflect into the interest. So I give you an example. If we look to a country like Nigeria, Nigeria is about 240 million population. So they should have a minimum of 20,000 patients with hemophilia. And I think up to the global survey of 2019, the number diagnosed in Nigeria is about 350 patients only. So this means that thousands of patients do not have care, or even they may die because they are not diagnosed and they are not managed properly. So realizing the challenges is a basic part in building your strategy. What are the challenges? And the challenges, I believe, to all the rare diseases will be the same. It's only the clinical condition that is different, or that some of the diseases have progressed into having therapies, or others that still, because there is not sizable identification of the number of patients globally, that the pharmaceutical industry does not find the scale of economy to invest in research and development of therapies. So as an example, there is a disease called factor 13 deficiency. And the prevalence of this disease is almost 1 per million. So if I try to collect the data in any country, they will be numbers by hands. So in Europe and in the US, we try to establish networks of rare diseases for these rarer inherited bleeding disorders, and tried to record our clinical findings, the management, the way to treat according to what we have. These data started to polarize. So some of these rare disorders, the companies developed treatment for it, because on the global level, we could provide data. We could find, so in some of the rare disorders, you will need not even regional collaboration, you will need a global collaboration in order to find the size of the information that can make the pharmaceutical companies enthusiastic to develop medicines for such conditions. So when we started to work with the World Federation of Hemophilia on the GAP, or the Global Alliance for Progress, we defined strategic priorities. And the first was to improve diagnosis and access to treatment for all people with inherited bleeding disorders. Two, if we have a national member organization, we try to build the capacity of this national member organization, which is a patient organization, to advocate for their rights. And even if we do not have this, we try to help patients group and work with them until we could reach to build a national member organization in the country. And it is one of the targets of the WFH, or World Federation of Hemophilia, is to accredit more and more national member organizations to their General Assembly. So, for instance, when we started in the East Mediterranean region, there were only probably fewer than 5-6 NMOs. Now, I think we are close to about 10 or 12 in the region. So this means that you need to do this, because when the people first know each other, you can deal with them, you can educate them, and they can advocate for their rights for the diagnosis and treatment. Share knowledge and build awareness through exchange of education and training. And this is really, really important. What we worked on when we started this program in Egypt is that I tried, together with the WFH, to bring all stakeholders to work together. And nothing is hidden. And all people should be involved, whether from the healthcare providers, whether from the patient organization, whether from the financing authorities, and from the community at large. Because the stronger your message to the community, the stronger is the support for the government to take the decision. And then define and promote practice standards, collect the data, and support clinical research to provide evidence to make the case for better care. And this is really important, is that the WFH is very unique in two aspects. One, that it has an annual global survey. I will show you some data from it during the presentation. But this means it gives us strength. I know how many patients in my country, and I can compare myself, for example, to Algeria or to Iran or to Turkey, the countries that probably are the same in my region. And so we can try to benchmark the practice and to evolve the practice stepwise. And the last thing was to improve access to safe and effective products through advocacy and product donations. Actually, in 2012, the previous president of the World Federation of Hemophilia, or even in 2010, he declared in his annual talk to the General Assembly that we want that the vision of the WFH is treatment for all. And we all knew at this time that the access is that only to 20% of the patients, and that the 80% of the patients, they do not have access. But later on, he was serious about his vision. He was not giving just a hope, because in 2014, for the first time, we had a donation from an American company that developed a new factor 8 and factor 9 at a much better safety and efficacy than the conventional ones. And they told us that they want to donate to the WFH what is worth to $1 billion donation over 5 years, to be distributed to patients in countries where they do not have access to products. And actually, I was on the board at this time, and we were really scared by this donation. But the president, he said, because we said it's a new drug, these countries cannot assess if there are any side effects. Are we promoting this company over other companies? We had all our fears from this donation. But he said one thing that made us immediately silent. He said, this vial, if any patient across the globe needs it now, should I raise my worries against providing him with the medicine? And we silenced this. And then he said, okay, I can understand your worries. We can talk to the company openly about your worries and what they should do to assure us. And the company really was generous. They appointed McKinsey to study the whole situation on how to receive these donations, how to properly store them, how to properly channel them, and how to educate all the healthcare providers and patients across the countries that will receive these donations. And he said, for competition, if companies think that we favor them, this company against them, then they should donate as this company donates. So imagine now that we said we will utilize it over 10 years instead of 5 years, but now we receive from industry donations worth $225 million each year from all the companies. And now we are channeling this treatment to 65 countries all over the world. And we trained doctors, and these donations helped to save lives of tens of patients in Africa, in Asia, in Middle East, and in Latin America. And in the meantime, it created the awareness to the governments that if you have the proper treatment, it works, and you should invest in this. So, for example, in Egypt, when we started receiving part of this donation, Egypt was buying products for about 25 to 30 million units. Now Egypt buys for 100 million units. And we are discussing in the Senate to double the amount to improve the care delivered to our patients. So you can see that things come together, can make a huge change. So we have what we said a step-by-step process to bring about sustainable care across 6 distinct but interrelated pillars. Building of a strong national patient organization through capacity. And the boys now of hemophilia, they are outstandingly knowledgeable, and they can advocate, they can meet the media, they use the social media, they build their case. I was invited to give an expert opinion to the Senate, and there were 3 patients from the hemophilia. I mean, they could take the hearts and minds of the Senate to support their case. So very important thing is to build the strength of the patient community. Okay? Improving medical expertise and care delivery through training. We have done during the last almost 20 years, tens of workshops of education. We know that the turnover of the medical staff is all the time there, and that maybe those who were trained, only 10% will remain and others will shift to other careers. And so you need this continuous training process non-stop in order to build it. Increasing accurate laboratory diagnosis. And so in Egypt, we are focusing on 2 or 3 labs to make the accurate diagnosis. And they are enrolled into external and international quality assurance. They are building their accreditation. And even we tell the patients, even if you travel for a long distance, the society will pay to you your transportation, but this diagnosis is once for life. So we need to have a very accurate diagnosis. And based on this, since we have 2 or 3 labs, only these labs will report to the National Hemophilia Society the cases. And so we have almost 80% of the diagnosed patients registered nationally. And we update their data all the time. If they move from one place to the other, so we know, and we exchange these data with the national health system or national health insurance. Now, after almost 20 years of work, the health insurance supports very much treatment of patients with hemophilia. So they are covered now from birth up to the graduation from school or university. They have full coverage from the national health insurance. And now we are discussing that this coverage should include the prophylactic therapy, which is, I mean, the cost is almost 4 times the normal treatment. Now, for example, there is a new medicine for patients with hemophilia called imicizumab, which is a revolutionary treatment. Normally, the patient with hemophilia, he receives the factor concentrate for prophylaxis 2 to 3 times a week in his vein, which is not an easy process, but we educated the patients to do so. With this new therapy, you only need to have the injection twice a month subcutaneous. And they are much, much more efficient than the factor concentrate replacement. Of course, they have their drawbacks, so you must have also a very well-developed health system to monitor any side effects. But I mean, the company came to us and told us as how much should you pay? I mean, how much should be the price for to launch the product into Egypt? And we said it should be like 20% of the global market price. And the company accepted. And now they are even giving a much better offer. They said, if you will change all the children into prophylaxis, we will match the price of the clotting factor concentrates, which is almost another 50% reduction. So when you have the data, when you have the health system, when you have everything in place, you can find solutions to help your patients. So this is what we say, an integrated approach between the National Patient Organization, between the medical health, our medical practitioners, and the government. This is what we call the golden triangle. And this cannot be created in a fortnight. It takes vision, strategy, sustained work, evaluation, and knowing what are the. If we look to the global data, for example, to see the vision, in 1999, the total number of patients of hemophilia was about 100,000. With all the programs that the WFH did, we grew to 2020 to be almost more than 380,000. This means that we quadrupled the number of diagnosed patients in 20 years. So this wouldn't have been possible except with sustain, because of course the growth, the population growth in developed world is much less than in developing world. So this means that many of these patients are diagnosed in the developed world. When we started the GAP program in Egypt, the number of patients, total number was around 3,500. Now we are close to 9,000 diagnosed patients. So you can see that the growth is coming mainly from the countries that they have more population or developing population. And this wouldn't have been there unless these programs are in place. Also, you can see here that, I mean, when I joined the WFH in the early 2000s, Africa, almost there was no single country except the North African countries, members of the organization. Now you can see that there is a significant number of African countries joined the organization. Same in Latin America. Same in Southeast Asia. So with these sustainable programs, we could attract more people. And having members meaning that you have the chance to build the systems to improve the situation. When we started the first gap with Egypt, we could later together work with the WFH to spread to Jordan, to Tunisia, to Algeria, to Morocco, and then there was less developed programs or less ambitious programs for the countries with less infrastructure. So there were twinnings running for with Sudan, with Syria, with Lebanon. And now my center is the International Haemophilia Training Center for all the Arab-speaking region. And we have built what is called the Network of National Member Organizations of the East Mediterranean region. And I started in 2018 an initiative to formulate a network called the HEMNet, Haemophilia East Mediterranean Network, to include all healthcare professionals to work together. And we have an annual forum meeting. We did, I think, now 3, and we are discussing the 4th. 2 were in person in Tunisia and Egypt before the COVID. And the last one, we did it in 2021 virtual. And mainly the basic thing is that we are trying in these meetings to identify our challenges and the need of research according to what we have to improve the situation. So for example, we discussed the prophylaxis. The standards of prophylaxis are very high in Europe and in the US. And we said, what if we try much lower dosages and frequencies and see the effect? And the effect proved to be, it is effective, and that several publications were published. And the effect did not only happen in the region, but extended to India and China to try the same approach. Some of the patients, they develop what is called factor VIII inhibitors, and there is a treatment called immune tolerance induction. And usually they use huge amounts of factor on daily basis. It needs a very sophisticated system. We said, why not to try on the region smaller doses at less frequent intervals? And so far, 2 publications were published from Turkey and from Egypt, proving that it is having the same effect, but probably takes longer time and with some more bleeding episodes compared to the high, but the end result is that you achieve the immune tolerance. And with this, we discussed many things, the circumcision as it is a ritual of the region, when to do, how to do, many things like this. So this networking across the region keeps the momentum moving. And also, we are trying to close the gaps in the diagnosis and the treatment. So if you see, for example, due to the sustainable effort, if you see the diagnosis, Europe is the highest, 81% of patients are diagnosed. And then comes the Americas, 54%, Middle East or Eastern Mediterranean, 42%, which reflects that the efforts done in the last 20 years is very... Likewise, we are trying to improve the access to care. Still, I mean, for example, access in the population is 12%, I think. We are trying to get more factor concentrates. Of course, the Gulf countries, they are very rich, they can access. North Africa, like particularly Algeria and Tunisia, are in very good conditions. Libya is in very good condition. Egypt is now growing to be in a very good condition. Of course, unfortunately, the disaster area like Syria and Yemen is problematic to a certain extent. Iraq used to be at a very high level, but because of the insecurity there is affecting. Iran is very high. Turkey is very high in utilization. We're trying to build for Pakistan. So you see, we developed a technique to virally inactivate the plasma products in a concept called mini-pool plasma fractionation. So the blood banks can use medical devices to produce the coagulation factors and the immunoglobulins in the blood banks with the same safety and the efficacy, so that they can also utilize their own resources and not to waste it. So I mean, working together can open channels to many, many things to happen. So, I mean, if we discussed this with Matt and you, Anka, before, that clustering different diseases per body system or organ, identify international experts, disseminate the model that you need to identify the challenges. You need to have like 6 or whatever the number of steps that will represent pillars to work on, including strengthening patient community, improving diagnosis, building national registries, improving, educating healthcare providers and patient communities, lobbying and advocating with the governments. This, and it takes very long time. It does not happen in a fortnight, but to have a clear path, it really, after 30 years, it pays. It pays for this.